Welcome to section 30 of the Anatomical Online Review. This is the section on posterior abdominal wall and the urinary development. The posterior abdominal wall has a few muscles in the diaphragm. We've already discussed the diaphragm itself. We need to know that there's the quadratus lumborum muscle and the psoas major muscle. Also, there can be a psoas minor, which is inconsistent and does not cross the hip. Here you can see those muscles, as well as the crus of the diaphragm, which we're getting a good look at here. The crus of the diaphragm will allow to pass the aorta underneath it and behind it so it doesn't get compressed. That's the median arcuate arch. And then the right crus will also be encasing the muscle of the esophagus. And this can get compressed, but of course it doesn't matter if it gets compressed there. Then over the psoas we have the medial arcuate arch and the lateral arcuate arch. These are really not that important except for the posterior trigone just after the lateral arcuate arch, and this is a potential herniation site known as Petit's triangle. Around the level of T12, the cisterna chyli will gather up the lymphatic trunks of the abdomen and drain them into the thoracic duct. These trunks will parallel the common iliac vessels and converge them to this site. Now we'll move on to kidneys and the ureter. Here you can see a posterior abdominal wall dissection showing the kidneys, the IVC, the adrenal glands, superior mesenteric and inferior mesenteric, along with the aorta, and you can actually see the left renal vein being crossed by that superior mesenteric vessel with the celiac just superior to that. When you cut into the fibrous tissue of the kidney, you'll see the divisions of it anatomically, and I know you'll talk a great deal about the kidney in the renal section of the course, so I won't go into that, but what you should look at is the renal and cortical columns, along with the pyramids, which will empty into the minor calyces, and then the minor calyces will drain into major calyces, and finally that will become the pelvis of the ureter. That renal cortex is where a lot of these glomerular tufts are going to be, and the renal pyramids are where the collecting ducts are going to be, and they'll drip urine through their apex into those collecting systems of the minor calyces. There's three constriction points of the ureter which you need to know about. One will be when the renal pelvis narrows into the ureter proper. Then they'll be at the pelvic brim when the ureter crosses the iliac vessels. And then again at the wall of the bladder when it passes through the bladder on a tangent which will act as a functional sphincter for the ureter. What happens with the kidneys and ureters? Well, there's two fascias that cover over the ureters and the kidney, and this will carry the fascia into the pelvis and provide a path for infection between the kidneys and the pelvis. Of the two kidneys, the lower of them is the right side because of the liver being in the way. The hilum will transmit the renal vessels and the renal pelvis, as well as the autonomic nerves, into the parenchyma of the kidney itself. And then there's going to be a renal pelvis, which will be the upper expended end of the ureter, as we've discussed. The renal fat and fascias will support and cushion the kidney, and there's a couple different fascia. One is going to be the renal fascia, which is going to be connective tissue right around the kidney itself in the suprarenal gland, and then there'll be a layer that divides that in two fatty layers on either side of it. One is the perirenal fat, which lies between the kidney and the renal fascia, and the second is the pararenal fat, which lies outside the renal fascia. Depending on where bleeding or fluid accumulations are, you can tell what is bleeding based on what's distributing to it. One thing is that if the kidney itself is bleeding, it's going to get into the perirenal regions. If it's the abdominal wall, there's going to be a sequestering of that in the pararenal fat. Looking at renal circulation, there's segmental vessels. Usually there's 5 lobar branches that will take it into different segments of the kidney because it forms as a lobar organ. And then the interlobar and the arcuate vessels will then become the afferent arterioles supplying the glomeruli. There can oftentimes be accessory segmental vessels as part of the development of the kidney. It will ascend from the pelvic regions up into the posterior abdominal wall where it sits in the adult, and if the vessels do not degenerate on cue, they can be remnant. The renal arteries will divide at the hilum into the anterior and posterior branches, and those will become the segmental vessels, one to each of the 5 lobes or kidney segments. The renal veins are paired tributaries, and they'll go into the inferior vena cava eventually, one per kidney. There's going to be veins that will, the left renal vein has to cross the midline and is underneath the superior mesenteric vessel. And the suprarenal vein will, and the gonadal veins, as we've mentioned earlier, will need to cross into that before it crosses the midline. The lymphatic drainage of the kidneys goes to regional nodes and posterior renal fascia and pelvis, and then it will go to the aortic nodes. As far as problems with the kidney, the stones are probably one of the most common, and there can be ureteric obstruction as a result of these stones. Renal canaliculi will typically lodge in these narrow points, resulting in hydroureter and hydronephros, which will back the kidneys up and can potentially shut them down. The ureteric smooth muscle will go in under an intense peristaltic contraction that can severely create intermittent pain and low back pain or abdominal wall pain and even external genitalial pain from T12 to the L2 dermatomes, as this very crystalline and jagged structure of a kidney stone will move slowly down the peristalsis of the ureter. And it's sometimes known as a marching pain. The polycystic kidney disease is a genetic autosomal disorder in which the clusters of the cyst develop on the kidney and will become non-cancerous. However, it also makes the kidney non-functional. The recessive version is a problem with the collecting duct system, and in infancy they will definitely need a kidney transplant or they will die. The dominant is less aggressive and typically doesn't show up with renal failure until adulthood. Let's look at a brief timeline for the urinary system's development. We know that there's going to be development from week 3 where the intermediate mesoderm starts to set up along the lateral sides of the notochord, and then in week 4 there are going to be cervical nephrotomes from the pronephric kidney. So there's going to be 3 different versions of the kidney until you get to the adult kidney. There's going to be that cervical pronephros, then we're going to get into the mesonephros, and then the metanephros, which is going to be the adult version. At day 28, the metanephric blastema and the ureteric buds are going to start to bifurcate and form the major calyces and minor calyces over the next couple weeks. The surface of the kidneys by the time it gets to 20 weeks will still be lobulated, and at 10 weeks they'll start producing functional filtrates. Let's go to a question. Unilateral renal agenesis was diagnosed by ultrasonography in a near-term pregnancy, which was associated with oligohydramnios. What is the most probable reason for the failure of the kidney to develop? Here you would be thinking of failure of the ureteric bud to form. There needs to be an interaction between the metanephric duct and the ureteric bud, otherwise they will not connect together. If you're thinking of oligohydramnios, well, the oligohydramnios is a symptom of the kidney not developing, not a cause. Degeneration of the mesonephros is a natural occurrence. The duct can be used again, but the mesonephros essentially in the male will get used in the testicle. The duplication of the ureteric bud is a simple splitting of that duct, and the unilateral polycystic kidney is an autosomal disease. So let's look a little closer at the development of the genital system. You can see at this cross-sectional cut with the transverse plane of the embryo, that there's a cord being set up along the entire length of the embryo off of the side of the neural tube and the notochord, and that's going to be the urogenital ridge. And those will be bilateral. Those urogenital ridges will start to form nephrogenic cords depending on where they are, either in the neck or the thorax or in the pelvic regions. As a result of the folding in the embryo in the horizontal plane, those intermediate mesoderms will now be lying next to the medial side of the embryo. And that's going to be causing the urogenital ridges. The nephrogenic cords will be the early primordial urinary system, and around the T10 region is where the genitals will start to form. So we've already mentioned there's going to be 3 sets of kidneys, the pronephros, mesonephros, and metanephric, and the thoracic region is where the metanephros is going to form. And about week 9, that's going to degenerate, except for the mesonephric, also known as Wolffian duct. The Wolffian duct will be used in the male system, not the female system, although there may be remnants of it in a female that can cause clinical problems. The metanephros is going to be the permanent kidney, and that's going to start appearing around week 5 and start to function around week 9 or 10. Ureteric bud is going to be induced to grow into the metanephric cap, which is going to be a diverticulum from the metanephric kidney. And then we're going to have the ascent of the kidneys as they get dragged up and start to rotate 90 degrees so that their hilum ends up in the medial position. And of course we've already seen the accessory blood vessels that will persist if they don't continue to migrate and change as the kidney ascends. Here we can see the primitive urogenital sinus and the primitive rectum, which is going to be separated off by the urorectal septum. And you can also see the mesonephric duct with its early mesonephros and the ureteric bud coming off of it. The important thing to notice here is that the mesonephric duct is going into the primordial or primitive urogenital sinus, and some of that will resorb into that area, and this will separate away the kidney from the ductus deferens. It's going to be used by the mesonephric system. This is what's starting to happen at this point from the posterior view. As it progresses a little bit more, that mesonephric duct is going to be resorbed by the primitive urogenital sinus as it becomes more and more closely associated to its adult bladder. So we're going to have 3 components to the urogenital sinus. There's going to be a vesicular portion, a pelvic portion, and a phallic portion, because you can now start to see the genital tubercle starting to rise off of the ventral surface of the embryo. Once the mesonephric duct has separated away and been partially resorbed into the urogenital sinus, what you're going to have is a separation from the kidneys and the reproductive system, which will be the mesonephric duct and the mesonephros, which will become part of the testicle, actually. So the bladder is going to incorporate the distal mesonephric duct. What will happen with this is that it will become the trigone. Let's go to a question. There's a 6-year-old boy that has a large intra-abdominal mass in the midline just above the pubic symphysis. During an operation, a cystic mass is found attached to the umbilicus and the apex of the bladder. Which of the following is most likely the diagnosis? What you'll be looking for here is not a Meckel's cyst or a Meckel's diverticulum, because those are associated with the bowel, but you'll be looking for a urachal cyst, which is the remnant of the primordial urogenital cyst. There's a couple malformations that are going to be possible because of the bladder formation, and one of the most serious of them is going to be exstrophy of the bladder, where there's an anterior wall folding problem that keeps the bladder on the external surface of the abdominal wall, and the trigone is going to be exposed. It's oftentimes associated with severe epispadias as well. There can be urachal-cysts, sinuses, or fistulas because of a defective or a failure to obliterate the allantois. And here you can see some of those where you have a cyst sinus which will drip, or a fistula which will connect all the way back to the bladder. So hypospadias with chordee is going to be a urethra that opens up on the ventral side of the penis or into the perineum, and is because of a defective closure of the urethral folds. The chordee is the ventral curvature of the penis. So there's going to be a tightening of one portion of the penis which will cause an extreme curvature. Here's a few more developmental problems associated with kidneys and the adrenal glands. If you can have one kidney that's not induced, you'll have unilateral renal agenesis, and that's going to be associated often with oligohydramnios. Although the other kidney can sometimes compensate, and this won't be picked up until later in life. The horseshoe kidney, in which the tails of the ascending kidney and the metanephric blastema will fuse together. The reason that they can't ascend into the pelvis or out of the pelvis at that point is because those inferior poles get hung up on the inferior mesenteric artery. With an ectopic kidney, that just means a kidney out of place. That will oftentimes be the result of a forming pancake kidney, where rather than just the tails fusing, the entire medial surface is fused together. And this usually has, rather than having a hilum towards the midline, you'll have a superiorly located hilum. Polycystic kidney disease we discussed already as creating renal insufficiency, and it's a hereditary genetic disorder. There's a bifid or doubling of the ureter, which is usually a harmless variation. And then there can be a more serious congenital problem with congenital adrenal hyperplasia. And any time that you see genitalia that are indescript, you automatically have to assume congenital adrenal hyperplasia until proven otherwise. In a male, this is going to have fairly normal looking genitalia, but in a female, their genitalia tends to be masculinized. Look at the development of one of the more important organs in the embryo. It's really a fascinating organ. I know you'll talk about it a lot in the physiology components as well as even pathology, but dealing with the anatomy of the suprarenal or adrenal gland is also interesting. It really has two components to it. It has a nervous component from the neural crest migration into the medulla, and then the cortical component, which is going to be an endocrine component. It's going to be one of the largest organs in the fetus by weight, and it's considered a very vital organ along with the brain and the heart. 85% of the gland is unique in its fetal zone, which will then be traded out as it develops into the adult version. It's ramped up basically as a fetal component, and it produces 100 to 200 milligrams per day of steroids compared to the 30 or 40 milligrams per day in resting adults. And in part, this is going to be part of the prolific growth phases that it's in. And just looking at some of the development of this, up in the early weeks when it starts forming at 6 weeks, it doesn't really finish and become the adult version until 4th year of life. By the newborn component, you're already starting to get a resorption of the fetal components that are hyperactive, though. When we think about congenital adrenal hyperplasia, we have an increase in the cells of the adrenal cortex, which will overproduce androgens. In the males, the genitalia look normal, but in the females, they're enlarged and masculinized. Therefore, in this female with CAH, you can see an enlarged clitoris and a fusion of the labia majora, which looks a little bit like a scrotum. This will conclude our component on the renal and adrenal development as well as the posterior abdominal wall. In our next segment, we'll start to discuss the pelvis.